very, sorry, I think Madhukar is behind a very evil plot to make me unpopular here. Because yesterday he asked me to speak in the afternoon after lunch, and today he asked me to chair after lunch. So both ways I don't have a chance. So anyway, we'll try our best. But fortunately for me, I think we have some very, very interesting speakers. So the job or the onus will not fall on me, but will fall on the speakers. And some of whom, at least Mukti I know and know of her work. We have met before. The others, though I don't know the individuals who are here, we know of their work. I was just telling Anand, we know his parents. In fact, the work that they were doing inspired a lot of the medical work that we are doing, the health work that we are doing. And so it's a pleasure to meet Anand, whose parents, Xavier and Rani, are legends in the field of healthcare for the poor in the country. They were pioneers for a number of years. So they started in 85, and in 87 when we started a health program, the two doctors who worked with us were inspired a lot by the work that's being done by their research. So Dr. Anand himself is a Master's of Public Health from Johns Hopkins University School of Medicine, and he also serves as a senior consultant in the Ministry of Health and Family Welfare for the Government of India. So he is the Research and Medical Officer of Search, which was started by his parents. And as I said, they have this concept of where they have brought the Gandhian concept of Swaraj into healthcare. And so they are the pioneers of communities managing their own healthcare needs. Mukti again is from CMC Vellore, trained as an occupational therapy, and took a master's in healthcare management from ACIC Hyderabad, John Hopkins University, and she co-founded the Healing Fields Foundation in 2002. And her contribution has been especially in the role of health financing, not just provision of healthcare, but also health financing and community health education. And their aim is to make quality healthcare affordable and accessible to the poor. Mukti is also the founder of AMIT, the Asia Micro Insurance Network, and is a member of CGAP, Micro Health Insurance Subcommittee, and is an Ashoka Fellow. Dr. Tripathy and Nirmala Nair are people whom I just seen for the first time, though I heard of XLRI. I don't know much about their work, but they have founded XLRI, and they work with the indigenous people as well as socially disadvantaged non-tribal people living in some of the undeserved districts of Jharkhand and Odisha. I am personally looking forward to hearing a lot from them, because I started my work in 74, close to Chakravur and Singhu district. I started living in the tribal village, the Ho village, in 74. So I personally am looking forward to hear a lot from them. And then we have Anirudh Kumar, who's a young person from the US who's doing a one-year, I don't know, is it a fellowship or it's a fellowship with the other big legendary project in India in health, which is CERHD, that is the Comprehensive Rural Health Project in Jamkhet. Again by two legendary people, Raj and Mabel Arole, who are they started even earlier in the 1970s, I think, if I'm right. In 1970, they started working in Jamkhet, and they were actually, to the best of my knowledge, were the pioneers of providing healthcare for the rural poor. They were probably the first two young doctors who went out to the rural area and started looking at alternative ways to provide healthcare. So Anirudh is a Mabel Arole Fellow and Programs Manager at Jamkhet Project. He has earlier worked at Mount Sinai Medical Center and the Center for Research on Environmental Conditions at Columbia University and at Albert Einstein College of Medicine. Himself, I think you're a medical student, and graduated or still studying? He's still studying. So he's, I think, a fortunate person to have got this exposure during his medical college, and so will be a very different doctor when he graduates, I hope. I'm sure. So welcome to this very eminent panel in healthcare. It falls on me to make a few preliminary comments on this whole issue, because one of the things that we are very concerned about in our own project and the work that we are doing is we keep using the word healthcare, healthcare, healthcare. We talk about a health system, but the entire allopathic system that many of us are propagating has very little to do with health management or healthcare. It is more an illness management system. So the amount of preventive, if you look at the resources, even in our own project, the amount of resources in terms of human resources and financial resources that is pumped into managing illness, and the amount of human and financial resources that is pumped into preventing illness is very disproportionate. And this is not because we intended to be that way, but the cost of providing illness management, we have no control over. We do not control it. There have been ventures in the country like low cost, which is another exemplary institution, which has been trying to provide medicines at a fraction, generic medicines at a fraction of the cost of the other pharmaceutical companies. Many of us hospitals, I'm sure all of you are buying medicines from low cost, versus a fraction of what the Pfizer's and other pharmaceutical companies charge. But in spite of that, the cost of managing illness has now become totally disproportionate with the cost of preventing illness. The second thing, when we look at, we will find that there are other factors that contribute directly to health problems: smoking, drinking, and so on. So on one hand, the NGO sector, which tends to be very holier than thou, they are always educating the poor. We are always teaching them, we are training them, we are teaching them, we are building capacity, skill building. They are always doing that. They have a very patronizing attitude towards the poor. And we tend to say that this is their problem because they drink alcohol, or their problem because they smoke, or their problem because they chew betel leaf. We don't talk about what the industry is doing to push these things among the poor. There's such a lot of thing that happens, and we have very little legislation to prevent this from happening. We had one minister for health who tried to do something, and he got shunted out before he could step on the toes of these big giants in the industry, the tobacco and alcohol industry. And alcohol is the single biggest earner for most of the state governments because of excise. So in our district, where people, tribals and some other communities, Badagas, have protested against opening liquor shops because they didn't want it. Government auctioned it. Government with police protection has opened liquor shops in these villages. Where women have protested and the government has, with police protection, has, because they have signed a contract, he has got it in an auction. So we have all these dichotomies. So we are really looking forward today to listening from this very eminent panel with a lot of experience on various interventions, some for very many years, like from the 70s, what has happened and what is the future. And as we all know, those of us who are working with the poor, that the single most common cause for communities or families sinking into poverty is a medical incident, a health incident. There just has to one thing, that's the single largest cause of debt. That's the most common cause for debt. People borrow at exorbitant rates, and families slip into poverty because of that. There was a study made a few years ago in Rajasthan, I forget in which district, and that has shown that people who have come out of poverty slip back into poverty very often. So we must not think that this is a linear thing, that you can come out of poverty and keep going up. They have found that over a 25-year study, they have found that everybody slips back into poverty. They might come out again, but they keep going back. So there's a cycle there. But even in that, the single largest cause was a health-related cause because of trying to get treatment. They sink into poverty. So we have to see health in a much larger perspective of what its impact on the economy of the people and so on. The Institute of Public Health in Bangalore has done some studies to show that actually out-of-pocket expenses for healthcare is much higher than We think the government is providing healthcare through government hospitals, but what people spend from their pockets is not accounted for anywhere, and it is actually very, very high. So the whole system is a problematic system. We need to look at it critically, and we need to find critical ways. We were one of the, I think, Jamket had a health insurance. Was it, I forget whether it's your or your had it? No. Then we can claim to be the pioneers. I'm not sure if there's somebody else. We pioneered a community, the first of its kind, a community health insurance package. Before insurance was open to the private sector. It was still with the public sector. And we started a thing which successfully ran for 20 odd years. And the government then stepped in. And the government agreed to reimburse our hospital for all expenses for private patients. But I must share with you the wisdom of our Adivasis, because our system was refinancing. We insured all the entire community, and the community used to pay back the premium to the hospital. When the government came and said that they will pay, we asked in all the villages of the discussion whether we should continue the insurance program. It was a unanimous decision from 312 villages that we should continue to pay the premium. But we couldn't legally take a premium from them because the service was being reimbursed by the government and we had to provide it free. So we put forward that problem. So what the community has done is, they collect the premium and they put it into a community health fund. They agreed that for 3 years they won't touch the fund, to let the fund grow. And from this fund now, they will try to meet out-of-pocket expenses. Somebody who's a long-term stay in the hospital, someone who has to go for a referral, some things that are not covered by the insurance program. That fund is growing steadily. It is offering financial security to the community, and it is being managed by the community themselves. So this is just to share with you the larger kind of canvas against which this session is will be conducted. And I will now hand over to this eminent panel, and I will begin by asking Dr. Anand to share with us his experiences.
Thank you. I shall try to share the journey of search over the next 15-20 minutes. That is search's logo, and his journey is basically in search of help for people in tribal and rural India. Like countless others of their generation, my parents were inspired by Mahatma Gandhi, whose political manifesto was Hind Swaraj. And similar to that, we thought for search, Arogya Swaraj would be the vision, which would mean that people are healthy, empowered, and are in control of their own health. Now, in addition to this vision, search also had this key question in mind, that we are facing an era of risk of knowledge divide, which means that the power of knowledge and research must be distributed. So how to facilitate the growth of research in public health in India to be able to solve our own problems was one of the key quests of search. Now, with this, the journey began, and as the journey begins, the first question that we faced were, where to start the work? And we decided to follow this simple principle. Go where the problems are, and not where you are a problem to start working. And so we decided to choose Gadchiroli. Gadchiroli, as you can see, is in the central part of India, 1,000 kilometers east to Mumbai, and around 100 years behind Mumbai. Heavily forested, infrastructure is poor, whether is such racism would cut off the entire district, and as many of you would be knowing, one of the heaviest districts affected by left-wing extremism in the country. In fact, one of the bastion of Maoists in the country. Paddy cultivation is the main source of livelihood, and forest, tribal mostly rely on the forest, bamboo, tindu, from which bidis are made, and mahua, which is used not only for liquor, which is generally assumed, but as a rich source of sugar and fructose in the tribal area. In fact, there is an interesting story which tells us very nicely about the issues of tribal in Gadchiroli. When we went to Gadchiroli, the tribal friends in Gadchiroli told us about a story. They said that the government of Maharashtra in late 60s came out with a GR, government regulation. The GR was, because tribal brew liquor from mahua, cut all mahua trees in Maharashtra. Forgetting that for tribal, mahua is one of the richest source of fructose and nutrition, especially during season, which is called Haruk month, where there is nothing to eat. Interestingly, the second part of GR was, toad is very nutritious, the oil of toad is very good, so preserve all toad trees in Maharashtra. Now, after telling this GR, cut all mahua trees and preserve all toad trees, tribal would start laughing. We could not understand, so we asked them, why are you laughing? Then they told us, mahua is the flower and toad is the fruit of the same tree. Some bureaucrat in Mandra in Mumbai thought they are different. In fact, what I do is that whenever the Indian Forest Service officers come to Gadchiroli, new officer, I tell them this story and wait whether they laugh or not. Generally, they don't. That is what Dehradun teaches them. So, as I was just saying, that tribal, 40% of district population is tribal. They don't like their own customs, their own issues, and or of course several issues and problems. And we started work in 1986, built this campus called Shodhgram, Search Village, where we are working with 150 of my colleagues there. The second question, of course, we faced was, what do the people need? What problem should we select for work? And we decided to follow the second principle. We can all be listeners. And actually, as all of us professionals know, being professional means it is difficult to listen to others. So we decided to follow this principle. Started organizing annual tribal health assembly where people's representatives from 60 villages would come together, share their issues, vote for the priority problems they want to work us on. For example, healthcare was a major need, so we started a community-based hospital, tribal friendly hospital, catering to about 25,000 patients every year, 700 surgeries. Also, malaria being a key issue, how to construct better cattle sheds which would shut down the breeding sites, insecticide treated bed nets, and mobile medical unit. And of course, ambulances, health education, women's education to empowerment community with the necessary knowledge. So, community health care, hospital health care, primary and secondary became a key component. With our search to find the problem, we decided to follow this principle as well. One accurate measurement is infinitely superior to 1,000 intelligent opinions. We argumentative Indians have opinions and generally they are wrong. So we decided to measure. Any issue we would measure. So we established what we called a community laboratory of 100 villages, creating what we call a village health information system, male health workers who would do population census, measure every birth and death, find the cause of death, and do morbidity and mortality surveys. What did they find? For example, in 1989, search found that the women in rural India, almost 92% of the women have one or more gynecological problem. Actually, with each woman having 3.6 problem, only 8% ever receiving any care. This was hailed as the study of the decade in the 80s and actually led to the transition of health from maternal only to reproductive child health, ultimately leading to the ICPD conference in Denver. We also found, for example, in 2008 and 9, through the same system, that the private expenditure on tobacco in Gadchiroli district, one of the poorest in India, is 73 crore rupees, which is more than the combined expenditure of the government on NREGA, ICDS and NRH, almost on which the entire UPA regime is built. So enormous tobacco health expenditure. This was the power of establishing a village health education system and measuring the morbidity and burden of any block. Now continuing with this measurement, we decided to follow another principle to tackle one more key problem. Life counts, so count every birth and account for every death. It's very simple to sound, but that tells us the true burden of and underreporting of child deaths and infant deaths and neonatal deaths in rural and tribal India. So with this principle, what did we find? The IMR of Gadchiroli in 1988 was 121, 60% of which were neonatal deaths within the 28 days of birth of a child. So we decided to follow this principle to solve the problem. The first Chinese Congress, People's Health Congress, how far a mother on foot can walk with a sick baby, healthcare must be available within that distance. So we asked ourselves another question, much before the IT boom. Can we outsource the child and newborn healthcare to villages of India? And we designed an effective solution which is community-based, available at home, protect against the main causes of neonatal infant deaths, and it must be low cost. And with this, designed the home-based maternal, newborn and child healthcare program. These were the first community health workers who were trained in providing healthcare to children. They were equipped with what we call a mobile intensive care unit, neonatal child intensive care unit, this kit. They visit every child and newborn, they measure temperature, they measure weight, they diagnose pneumonia using measuring respiratory rate, they provide health education, they provide breastfeeding support, and they provide injection gentamicin in the case of neonatal sepsis, severe infection. They also provide care to mother, measure their blood pressure, check for any danger signals during pregnancy, their weight, iron folic acid supplementation, home visits, fever, any abdominal problems, and equip finally with mobile to ensure immediate ambulance care in the case of emergency. And what was the impact? The deaths in children due to pneumonia. This is possibly one of the longest running continuously monitored program in the world for community-based pneumonia care for children. Before treatment, 13.5% of children with pneumonia would die, and consistently for almost past 24 years now, after providing treatment, less than 1%. So enormous reduction in pneumonia child mortality in rural country. And this was the impact on infant mortality, 1994, actually 1998 to 2000, again 3. When we began, as I said, it was 121, came down to 80, and then with the home-based newborn care, came down to 30 by 2003, and now almost 25, which is apparently the goal India is committed to under the Millennium Development Goal for the entire nation, which these villages in Gadchiroli achieved much before the rest of the India. It was published in the Lancet. This is called Vintage Lancet, one of the finest scientific paper in the history of Lancet since 1823. And general perinatology. It is a part of the 11th and 12th 5-year plan being implemented across the country through the ASHA program. The Government of India has released these specific operation guidelines, and in Gadchiroli we are continuously involved in training trainers and program managers from across the country who ultimately train ASHA, 8.5 lakh ASHA across the country in providing home-based newborn care. So to briefly summarize what were our learnings in the experience of Gadchiroli over past 27 years. First is that community plus local action plus science, if this triplet they go together, then we invariably find a national and global policy change. In other words, the power of research. Archimedes said this almost 2,500 years back, "O king, give me a river long enough and a place to stand outside the earth, and I promise you to move the earth." We know by the principle of river that even if he sounded foolish at that time, this is correct. That is the power of research. High quality research done in the villages of Gadchiroli can change the policies of Delhi, Geneva, and Washington. And finally, what we consider as the key paradigm, the key contents of how to work with the people. Number one, people should meet it. The problem, as we saw, we must listen to people. People should understand the work that we are doing, not isolated professional distance. People should participate in doing it, the key theme of this conference. People should use it, and finally, people should own it. Thank you.
Would you like to ask questions now itself after each speaker? There are many speaker-specific questions, and maybe at the end we can take some general questions from different speakers. Just one or two quick questions.
Hi, my name is Ditra, and I just wanted to ask. You spoke about you spoke about your work, but how do you go about looking for doctors and keeping them and retaining them?
That is a consistent struggle. I think partly we were fortunate because of the family of doctors that helped, and partly I guess when young doctors, they found professional excellence, as I see, and the mentoring, which is necessary, especially at the early stage, that definitely helps them in joining an organization. So the excellence and making them understand the larger context of the micro work, think globally, act locally. That would, I think, and that has helped in our case in culturally and athletic doctor. And third, I would say that the over dependence on allopathy actually. I don't mean Ayush, by the way, I must clarify. I don't mean that. What I mean is that non-allopathic doctors, that we train community health workers in doing that, but non-allopathic doctors can be trained in providing allopathic services. So I think we must look at all options.
Any other question, or shall we move on to the next speaker? Then can I invite Mukti to come and share with us her experience?
Thank you, Steph. Yeah, I feel like an infant standing in front of Serge, in front of CHRP, and in front of Dr. Nirmala, Dr. Tripathy. Our journey started almost, I think we were babies, or we were not even born when Dr. Arole started this program. I grew up all my life near Vellore, learning about everybody talking in awe about Dr. Aroles, who moved to Chamkhed as a young couple and started this program. My mother visited them when she was a student, and so grew up with that and the community health program in CMC Vellore. And when we started Healing Fields Foundation and we wanted to go on the micro health insurance journey, the only name which kept coming up was Accord and AWS. And 20 or 15 years ago, when we first held our first introductory session to introduce Healing Fields Foundation, we had a seminar on micro health insurance or health insurance itself, health insurance as it is in India. And the only program that was in action and that was doing some work was TAN's work in Gudalur. So I think I just cut my teeth into the community health and into micro health insurance thanks to Stan and Dr. Arole's Jamkhed program. And of course now Serge, Dr. Abhay Bang and Rani Bang keep reading, keep looking at their program and learning so much. And there's so much more to do in this country and I guess across the world. And when Professor Madhukar told me out of the blue, he calls me about 3 weeks ago and said, Mukti, you have to come. I said, who are coming? He said, oh, Serge at CHRP and Dr. Tripathy. I said, I'm not coming. I said, you have them, so I don't need me. We are technologically challenged. Our journey started, as Dr. Anand says, listening. So I spent 2 years of my life just listening, 1998 to 2000, understanding what is it that the community wanted. Because we always think we have the answers, We know what the problems of the poor are. We have the solutions. But in reality, we don't even know the surface of the problems. So 2 years of my life I just spent moving from place to place, getting emotional, losing sleep, losing sleep. Joe, that is why I need the 12 hours of sleep, Joe, if you're here. And learning about the actual problems of the community and what they see as the problem that they have. It has to be relevant. Whatever solutions that we assume that we are making has to be relevant to the community, to the needs of the community as the community looks at it. And the second important part was ownership. They have to own the solution that you may come up with discussion with them. The solution that you may offer is not the solution that they may want. One of the important learnings for us from micro health insurance program was everybody said, okay, give money 350 rupees per annum as a premium is nothing. When a person is paying about 500 rupees just to the microfinance loan and about 24 to 30% as the interest rate. But when we went in there, everybody said that they will pay. But when it came to paying, nobody was willing to pay and put up that money because there was something else that was needed. And so it was really not relevant. The community had not owned it till we shifted the whole onus and the ownership into the community, saying what is it that you want? If you want to go to the hospital, what is it we want? And what we would think is access to the doctor, but more than anything else, the women whom we worked with wanted respect. And unless you spend time with the people there, you're not going to understand what that means. Respect when you enter a hospital, that you are treated as well as another patient who has the money to pay. And that was an extremely important part of the person when he or she would pay the premiums. So, and also they need to own the person who is going to take you into the hospital to show you the way around the hospital. If they don't know you, don't know the person, that means it is irrelevant to them. You can be whoever you want to be. You can go in into your swag cars, you can go in as a professional and talk about all the numbers and figures. But if that person out there does not know you, does not know your commitment, does not own you as a person, all the work that you do, you will just stay still there. Participate. The third important aspect that we believe that is very important in any kind of community managed health system is participatory monitoring. In all our work in the last 15 years, we thought that we were monitoring. Till we realized that one day we had a person going into the hospital and we realized that for the last 2-3 months, the networked hospital, we didn't have patients going in. And when we started looking at why that particular hospital nobody was going in, is it the fact that the people are not falling sick? So we went back to understand why people are not going into that hospital, even though we had a paid staff as a facilitator in the hospital and everything was hunky-dory, till we went in to find out because the data that was coming was not being relevant and not being real. So when we went and found out, we saw that the community members were not going into that particular hospital because they had 2 types of benches. One for the low caste people and one for the higher caste. And so that was a huge mark of disrespect to the person, to the whole community, and they were being treated, even if they came in very early in the morning, they would not be seen much later in the afternoon because they had to wait till all the upper caste people were going. So the first thing we did is blacklisted and removed the hospital network. And this particular hospital came from the community themselves. They identified this hospital as one of the network hospitals that they wanted, and because it was an aspirational hospital. It was not a hospital that they were using. When we went and asked them, they said this was a hospital that we would like to go to because all the rich and the upper caste people were going there. And then they realized that they were not treated with respect. That we had to pull that out. So the participating, at that point in time, we learned a very hard lesson that was very early in our journey, that we need to involve the women that we are working in anything that we are doing as well as monitoring. Today we have the PhD engineers asking our community health facilitators to monitor the work done. That work is being done by the government functionaries in the villages. It has come to that level, and that is the level of training that our community health facilitators get. Our journey, as Tan said, we started off in 1998, unofficially started listening, started working to really understand whether we really wanted to go on this path or not, and maybe I was a late starter in life, and 2 years down the line we registered ourselves as a society, and the first program we did was actually a health education program for community animators of MB Foundation in Hyderabad, and they were working in the districts and with women, and these community animators would go and do preventive health education. It was a 1-year program, and out of that, one of the major needs we realized was access to health financing for for accessing quality hospitals. And that's how the micro health insurance was started. And we did a pilot. We rolled it out across 7 states in India, and it was relatively, I would say, a relatively successful pilot, because very early in life, going back to what Stan was saying, we always look at healthcare as an illness, as a disease. For all of us, when we talk about healthcare, we don't think about being healthy, being well. We only think of hospitals, and you go to hospital not for time pass. You don't go to hospital just because you have nothing else to do. You go to hospital because you're sick or somebody else is sick, and therefore you go to the hospital. And we looked at why should we, again, healthcare should be the domain of hospitals. It should actually be need to get into prevention, get into wellness, and that is again a lesson that we learned from micro health insurance, because most of the patients that were coming in were illnesses, common illnesses, which were preventable. And the preventable illness was going into complications, and they had to get into hospital, and one event of hospitalization, one incident of hospitalization would put down about 50% of the population, even from the so-called lower middle class, into below poverty line. The death cycle just keeps increasing, and today it just got spiral. Even the middle class family with one open heart surgery will have to will go back at least about 2-3 years down their savings. So we said, let us get into the prevention aspect, how to prevent illnesses so that they don't need to get into the hospital for treatment. And as part of the micro health insurance program, a large component was prevention by the facilitator who go into the hospital, so go into the communities and villages for follow-up, as well as educating the community members in terms of preventing illness. And from that, we started the community health program, the community health facilitator training program. The way that it is offered, it's a 1-year program. For the first 6 months, it's 4-day of contact training program every month. The women are members of either a self-help group or a microfinance institution, where we work in collaboration with them. We are a great believer of collaborative work, because we believe that we cannot possibly do everything on our own. We need to collaborate with others who are good at what they are doing. And if we collaborate, then the impact that we would create is much larger, much more sustainable than just one person, one organization trying to do everything. So this is a 1-year training program across 7 states that we do, starting with Andhra Pradesh, Bihar, Orissa, UP, Chhattisgarh, Assam, and a little bit of work we've started in Tamil Nadu. And we work with microfinance institutions and self-help groups. They help us pick out the community health facilitators, and we put them through a 6-month program. 4 months a day they come to us for training, and the rest of the days they go back home with homework that they have to do. They have to do surveys. We always think that these poor women who are semi-literate, what is the work that they can do? And she collects data. She does village mapping. She does the first month, and she learns basic nutrition, basic sanitation, hygiene, and then the second month when she comes to the data, we teach her how to analyze that data, very basic analysis. What is the problem that the village has, and what is the possible solution that they can come up with, and what is the solution that is going to be relevant. So per village, we have 1 community health facilitators. The rest of the month, these community health facilitators go and implement what they have learned in the 4 days of classroom session. And under the supervision of one of our field coordinators who are staff there and who will handhold them and move it forward. And they have a lot of writing to do. They have a lot of practical work that they do. And there is a dual focus. One is on the health outcomes of the community health facilitator training, and the second one is income generation through livelihoods, through different products and services that they learn to introduce to the community in the next 6 months of the what we call it as internship period. The first 6 months is learning. The second 6 months is intensive, what we call it internship, where the women go and to educate the community, create linkages into the different government and private providers that there are, as well as build toilets through the subsidy that the government gives, as well as taking a loan from the microfinance or self-help group institutions, as well as create other livelihoods like sanitary napkin production and sale distribution, as well as vision testing, because we believe that we need to access all that is available in terms of healthcare for this community that's available within the community, because we cannot possibly do it ourselves. So we need to be able to collaborate. And one of the great things of coming to XLRI for these conferences was the last time, thanks to Madhukar, we met Mrityunjay here, and we have started a great collaboration in Bihar with Mrityunjay's Akhand Jyoti Eye Hospital. And it is a win-win for Akhand Jyoti as well as for our community health facilitators, because they earn an income and they also learn how to conduct health camps, how to do vision testing, how to refer them into the hospital and become and prevent blindness within the community. So it is a win-win for both of them. And the same thing we have done with the sanitation. Now I'm hoping that we would be able to, I'm a great fan of Joe Maria's water and sanitation program, so we are hoping that we would be able to work together on that and move that forward, because we already have presence. We have about 1,000 community health facilitators trained in about 950 villages across the 7 states. So therefore, we will be taking that forward and working with microfinance institutions as well as self-help groups and the women. One of the important things is education is great, but what beyond education? Now they have created prevention. Now they fall sick. What next? And of course, you have the government programs, of course, you have the government facilities. But where they get a hit is when they fall ill. They don't have the 250, they cost about minimum 250 rupees to access any kind of outpatient care in any of the hospitals across India. Of course, it will be different in Status Hospital or Surge or CHRP, but most of the places it's about 250 rupees. That is not available, and therefore they just go to the local Kirana store and they can differentiate medicine according to them doesn't work. So they need, at that point in time it was nice. Now they want ibuprofen and they want other stuff. You give them Jerusalem, they say, this is not for pain, stomach pain, it is for stomach burn, so I don't want this. And they don't go into the quality provider, they just go to the Kirana store of the local pack. And so their whole vicious cycle starts. So we said, let us break this at this incident itself, at the first step. We have started forming health savings groups. So from health financing, for health insurance, we stepped down, because in many of the areas, the urban, semi-urban and the south of India, there are a lot of hospitals that you can access health insurance. Health insurance is useful to a person only if there are hospitals. If there are no hospitals, what's the point of me having a premium? So we said we need to step down and look at it, strike at the root, and be able to give health financing for women and communities where they can go and seek out outpatient care. So we formed self-help groups within the self-help group, and they save money within the community that's available 24/7. We didn't have to do anything. The women knew how to do the whole self-help group, how to get them together, how to keep their accounts, what is the interest rate that they were going to charge, and that they started multiplying. So now we are hoping that once, as TAN has taken the step forward in health insurance, we are hoping that they would do the pilot in the community health fund, and we would be able to learn from their experience and see how we can create a community health fund across districts, across states. so that there could be a bigger fund where what the insurance, the government insurance cannot provide, whether this fund can possibly provide and be able to grow that. And that is a challenge to any of the youngsters here who have a financing background. If you want to look at it and if you want to study this and be able to be a co-creator of something which is exciting, I think you should talk to either Stan or me on this so that we could work out together. And any kind of livelihood that we do, we take a three-pronged strategy. One is we go and identify whether there is a need in that particular community for that particular health product and services. And the next thing is we do an education. Even for the sanitary napkin, the first thing we do is we do a health education program with adolescent girls in schools, in the villages, and with young women and mothers. Because the mothers are the ones who are very, very careful about the girls and they want the best for the girls, even if they are not able to afford it. And we go and educate them about menstrual hygiene and about the importance of hygiene during menstruation, what is the kind of material that they will use. And after which, if they are using a cloth, so be it. We teach them how to wash the cloth, how to dry the cloth. But without toilets, there is no privacy, either to dry the cloth or to wash the cloth. So therefore, we introduce even the sanitary napkin. This is again, like I can go back to Joe's very famous verse. We don't believe that we need to offer poor solutions to the poor. I have been told many a times that you are the Mercedes-Benz for the poor, and the poor don't need a Mercedes-Benz, they just need a small little open share auto or a share Jeep. Why? If the poor can pay, and if you can get a Mercedes, why not? And so we came up with the sanitary napkin, which has become very powerful there, because many of the girls have started going to college, many of the women have started going to work, thereby improving their own livelihood income that they are earning, as well as improving their education, and thereby postponing the marriage. How many of us have 16-year-olds having babies in the villages? And that is mainly because what do I do with a young girl who's hanging around the house, who's 13 and is started menstruating, and what do I do with this girl? So the best thing is to palm her off and get her married. So then the responsibility of the parents is washed off. So therefore we started this program, and the sanitary napkin is as good or better than what is available in the market space. We have done a study. We have compared other sanitary napkins that our women are producing compared to the private market ones that are available, and ours is as good or better. And it costs only 15 rupees a packet of 6, and each of the women buy one packet a day, one packet a month for their girls. So this becomes income generation because the distribution channel is from the community health facilitators that we have. And the community sanitation, again here, as I told you earlier, we are a great believer in collaboration. We have collaborated with Goons for the last 2 years now, 2 or 3 years, where again, going back to the community, look at what the community needs. Winters in Bihar is terrible. And we have seen children dying. We have seen children coming down with pneumonia. We have seen the old dying, and we said we need to do something about it. And that is a need that came up from the community for warm clothing. So we started trying up with Goonj. The first year we took 1 truckload of clothes to be distributed. And again, we don't believe that we need to do charity, we need to be giving it all free. So we charge for all our services. For the community health facilitator training, we charge the women 100 rupees a month, which of course is a drop in the ocean, plus 4 days of work that they give up. So it is 100 rupees into 4, 4 plus 100 is 500 rupees a month that they have to set aside to be able to come to do our program. And for this, they have to buy the sanitary napkin, even the clothes. They will decide on what is the sanitation work that the whole community will be doing, and after which the clothes again will not be distributed for free. If the community health facilitator, the community would decide as to how much they would charge for each of the clothes. It can be as small as 1 rupee, 2 rupees, 5 rupees, 7 rupees, so that it would at least go towards the chai pani expense that these people have. And this time when I met Anshu here, one of the things that Anshu told me was, my team says your team is very well organized, which was very, very heartwarming for me, because now I think we are also learning with the collaborative effort. This time I think we have taken out 2 or 3 tons of clothes from Anshul to be distributed in about 428 villages that we covered. And by about August, September, we have people coming to us, to the community health facilitators, saying, when are you coming? When is the clothes coming? When do we start our sanitation initiative? And when will we get our clothes to come to us? So these are the collaboration. Ultimately, if we have to be successful, we need to move away from the paradigm and the box that we are in. Healthcare does not mean hospitals. Healthcare to us means wellness, responsibility to the community, and collaboration with the community and other providers within the community, so that we can together create a greater impact. Thank you.
Any questions for Mukti? If, then I'll make use of my prerogative of being the chairperson to actually just make a comment that one of the things I enjoy about coming for these sessions is you always learn something new, and in the more unexpected kind of ways. In all these years of this work, I never made a link between early marriage and the lack of sanitary napkins. I think this was a real learning for me to see there is a link in this. We never even have thought about it. A few years ago, at another conference, we heard about Gunj and realized that sanitary napkins was not even on our agenda for the health. We are looking at antenatal care, infant mortality, and all these issues. We didn't even look at sanitary napkins. So a few years back, that came on the agenda. And now to see this link between sanitary napkins, I found was very interesting. The other comment I just wanted to highlight, because Mukti kind of brushed past it over with a sentence and a comment. But one of the things about the Healing Fields Foundation is, she mentioned it, but it's a collaborative approach where they don't reinvent the wheel. And so there are organizations who are capable of mobilizing the community, then work with them to bring in value addition there. I think that's another very important lesson to take away from their initiative. So thank you, Mukti, for your presentation and for these insights. I'll move on now. I'm just following the order of the list here, so there's no particular reason for this order. I don't know whether you'll ask me to speak jointly, separately. So Dr. Tripathy will be speaking and explaining to us the work of Angel.
I didn't hear the clapping. Few people were moving. I asked my friends in the village I live, how many of you have heard of Delhi? And all of them will say, but how many people in Delhi know about us? Then they laugh. So I was not surprised Sten did not know about us. But I began my career visiting almost every other year Jamkhed. Raj and Mabel were the inspirations. And everything that we do today is because what they did in Jamkhed. We are also inspired by work of Sten. So, I met you when I was a director program in action, and I didn't know at that time that one day I will be leaving my job and coming back to Jharkhand. In 74 you were in Chairasa. I was a medical student at that time, and Nirmala and me, we live in a village in Jharkhand. So perhaps this is the first presentation from Jharkhand happening here. So better listen, don't sleep. And the place from where we work is only 80 kilometers from this place. So students interested in visiting us are most welcome. Since we started quite late, we don't do quite a few things that some other stalwarts did, and I really respect them, but we won't do it the same way. So we don't have campus, we don't run hospitals, we don't have buildings. If we close down today, we'll be very happy that something got done, and you will see in this presentation. And there is a reason behind that, because every time people ask us about sustainability, and to figure out all that really needs years of work. We just started 10, 12 years back, so we have to plan it that way. But patients do come to our house and they do get treated. We don't charge fees, because once we start becoming popular, then we won't be able to manage our workload. In fact, we were getting overwhelmed when we started our work. Too many people visiting our place, many of them getting well and some of them dying also. So it was important for us that we run away from our place and set up an office. That's how Ekjut work started in 2003. By the way, Ekjut is pronounced as Ekjut by colleagues from South India. So, so we are Ekjut. Ekjut means togetherness in multiple Indian languages. Togetherness in Hindi, in Odia, and many other languages. So let me start. Here is my first slide. I'll show you a few slides. It will be followed by a film. So the facilitator will not be able to, cut short my film. So the entire thing you will have to see. I'm sure we are already we have overshot by a few minutes. Last year, this was a famous tweet as far as the people in Ekjut are concerned. The editor of the Lancet, one of the highest impact medical journal in the world, tweeted after our paper was published. This is our paper in 2013. But the pooled analysis of the kind of work that we do was published and showed some astounding reduction in maternal mortality. Just women coming together, chatting, telling stories, solving problems, and saving lives. It was not drugs that saved their lives. It was not any device or vaccines. It was a problem-solving skill that got built during the process of community mobilization and saved life. And this was published last year in the Lancet. But before that, in 2010, when we published our work in the Lancet, these are the kind of response we got in various popular newspapers and magazines. I just picked up a few. There were many. We didn't get a hard copy of any of these because these newspapers and magazines don't reach our village. We came to know about it later. There was an editorial in Samaj, which is the oldest Odia newspaper, and the Time magazine also wrote about a story, and so on. But why am I showing all this? You have to give some excuse for making a little bit of public relations, like my friend Anshul did in the morning. So I am showing it to tell you that by media, it was very easy for people in media to understand what we did. Our friends in public health paid no attention to what happened. But this is something very interesting, and I can't believe that people writing in Odia, Bengali, Telugu, and so many other different languages could see that something very powerful has happened. But people in Ranchi did not know about it, and certainly my colleagues in public health won't even like to talk about it. So what had happened was, actually, women went through monthly meetings, just one meeting every month saving lives, so why should we be building a hospital? That's the thing. So, they met every month. They had meetings in 4 phases, means each phase having 4 to 5 meetings. The first few meetings were about identifying and prioritizing problems. The other meetings were about, learning about causes and effects and finding feasible solutions and looking at the barriers and finding strategies and evaluating it together. But to convince to the experts, you will have to do a robust evaluation using some other quantitative methods, which was also done parallelly, and compared with similar activities, compared with panchayats where women's group did not go through this process. Basically, it was a cluster randomized controlled trial. In 200 villages, you have existing groups, but in 200 other villages, these groups open up to non-members because my friends in development sector told me that women's groups exclude poor people. So might as well allow them to open up. It's like a club opening up its membership to non-members on a Sunday when the facilitator comes. And every month they had a meeting. I'm not going into the details of what happened in this meeting, but these are very simple, and the entire intervention is done founded this simple. Like for example, in one meeting they vote with pebbles on which problem they will like to discuss. That's all. That's the only thing that happens in that meeting. Or for that matter, in another meeting they're discussing how to go to the other side of this bridge. The other side is where you have good health. And the plans are the strategies that they have decided. So they discuss, they put different plans and they come up with a number of strategies. I'm not getting into all those strategies because sometimes people like to list these strategies and try to replicate and don't get similar results. But strategies have to be different for different villages or have to be context specific. And it all ends with a community meeting where women present their learning to the rest of the community and seek their support. If they have to demand services from the government, that is also discussed. There are a lot of things that can be solved in the community itself. So if you look at can I go back? There was 45% reduction in the last 2 years of a 3-year trial in neonatal mortality rate. The women's groups just met only once every month. So this was quite a powerful thing, cost effective by, like you do any kind of any cost effectiveness study. Disability adjusted life years saved was very low. We also replicated it in the control area after the trial was over, and again we got similar results. And then I'll stop here. If you look at the top graph, this is very interesting because Anshu wanted to know about it. Because nobody has counted how many deaths happens in the winter months. He was asking them. Interestingly, the first time we have proved that there is seasonality in neonatal mortality. That deaths goes up during the winter months, as you can see the first graph. But if you see the lower graph, you will see that some sort of deseasonalization is happening. Women's group members seem to have weathered the weather. And now, based on this learning, okay, I'll come to that. When we looked at the mortality reduction among the poorest, we found that they have benefited the most. So, when home-based newborn care program that our friend from Search mentioned is being scaled up across the country, is scaled up. If it is supplemented by another program which also reduces mortality among the poorest, and the homes of the poorest may not get visited for home-based newborn care, at least during the initial part of the program, because given the rural reality, the poorest homes don't get visited. So we think that what we have developed can supplement what has been developed in Gadchiroli to reduce mortality of children much farther. And this fact was understood by this person. During the filing, when the filing stuck, thousands of people were saved. This was a culmination of years of community-based disaster preparation work, and thousands of people were saved in the eastern coast. But another thing he did last year, which nobody came to know about it. This is something that we had developed in our village and which was replicated and published in Lancet. A program called Shakti Varta has been launched in Odisha in 24,000 villages in 15 districts, underserved districts. So it's something that was developed as a small pilot 10 years back, was proved to be effective in 2010, published in the Lancet, presented to the Chief Minister of Odisha, and his enlightened self-interest understood that people of East Coast needs to be saved from the cyclone, people in the western side and tribal people need to be saved from the vagaries of winter, and Shakti Varta was launched. So in this short presentation, what I have tried to show you is that we need to build evidence. We need to publish it. Either we use a publication route or we use other methods of communicating that it works. And we need with quantitative scale up, we also need political scale up, and government accept for scaling it up. Now, today, after 8 years, we started with 250 groups, saved 180 lives. Today, as I speak, more than 50,000 groups are meeting every month with an attendance of about 20 each group. More than 1 million women meeting every month, led by women, discussing on health. This is the largest community mobilization on health led by women in the world, and it has happened in India. And what I show you, this program is called, but it is called in Bihar, it's called Gram Varta. In Jharkhand, it is called Maitri Baitak. In Odisha, it is called Shakti Varta. In Jharkhand, it is called Sajha Sehat, and it keeps scaling up like anything. And my friends in public health in Delhi are not aware that this is happening. 2 months back, I and Nirmala were invited to Harvard Medical School. We made a presentation there. The health minister of Rwanda was there. Rwanda is one country which has the highest reduction in mortality anywhere else after the last, 1 million people were killed, there was a riot between Hutus and Tutsis, but now things are looking up. They have an enlightened health minister. She has written to me that we would like to adapt it for the entire country. So I hope people in our health system understand the benefit of this method and they invest in women's empowerment. I'll show you a short film. You will have to figure out it. So at the end of the film, I'll just ask one quiz. It won't take more than a minute for you to answer. Where did you see the intervention that was developed as a model and proven to be effective? Now we have integrated it into a program for combating malnutrition. So there are a lot of things bundled, but you will also see participative learning and action happening there. So that quiz I will ask after this film is over. Thank you. Can we start? Switch off the light.
And the mother looks on. This attention, this measuring, all this for my child? Between 2005 and 2008, in 200 villages and hamlets in the bordering districts of Jharkhand and Orissa, 244 women's groups met every month and went through a process of participatory learning and action meetings. They succeeded in reducing newborn mortality by 45%. This finding was published in The Lancet. Ekjut's work was extended to more than 200 other villages, the control villages, and got similar results.
We have seen the results through an equity lens and we find that the poorest have benefited the most. So we wondered if this method can also be used to consider and start discussing about problems of undernutrition among very small children. Because the immediate short-term and long-term consequences of undernutrition among very small kids can be quite devastating.
We know that malnutrition is a very complex problem, and we are trying to make this more visible to the community. And this is done through the participatory learning and action cycle, where we empower communities, especially women, and trying to make it more visible to them. And this is also done through home visits, where mothers of children 0 to 3 years are counseled on child caring and rearing practices. And there are also some sessions that we run.
Anthropometry is an integral part of our fight against undernutrition. We measure height, weight, and mid-upper arm circumference. Anthropometry may be a big mouthful of a word, but it is simple to understand when translated into colors: red, yellow, and green. And the mother facilitated to understand what each color means and what she must do to move her child out of the red to yellow and finally to green. Mid-upper arm circumference and plotting on the growth chart makes the child's nutritional status immediately visible. They signal the progress made and the weight gained.
फैसिलिटेटर ग्रोथ चार्ट के माध्यम से माँ को बतलाती है कि प्रत्येक महीने उसके बच्चे का वृद्धि किस तरह से हो रहा है। इस केस में बच्चे के वजन में काफी अच्छी वृद्धि देखी गई है। बच्चे के 21वें, 22वें, 23वें और 24वें महीने में काफी अच्छी वृद्धि है। बच्चे के बढ़ते वजन को देख के माँ काफी खुश होती है और वो चाहती है कि इसी तरह से उसका बच्चे का विकास होता रहे।
How is the weight gain to be achieved and sustained? Our ongoing work shows that undernutrition can be successfully managed at community level by using a multi-layered approach and by strengthening government services that are already in place at the grassroots. It all starts with the women's groups meetings conducted once a month in the village. The facilitator initiates a conversation. The women pick it up, one voice at a time. Here the facilitator is introducing a new concept: food diversity and how locally available foods can be used for a balanced diet. The women participate in mapping each food item as an energy food, a protective food, or a bodybuilding food. Government appointed grassroots workers like this Anganwadi Sevika also participate. Her active involvement sends a positive signal to the community that we are all working together to fight malnutrition. She becomes more accountable as her role and the services that she is mandated to provide get highlighted. Out in the open and open to all, the meetings are a form of social networking that are as engaging as any of their virtual counterparts. The meetings create quite a buzz. They're all about small steps and small things that are doable, such as including 1 or 2 items from each food group in the daily diet, adding oil to the khichdi for energy, increasing the number of feeds, increasing the food portions.
और हमारे जो फैसिलिटेटर हैं और अपने गांव में बैठकें करती हैं और हमारे हर बैठकी में अलग-अलग मुद्दा पर काम होती है, जहां खान पान, कुपोषण चक्कर, खुले गेम के माध्यम से समस्या को निकालना, उपाय निकाल करके गांव में परिवर्तन को देखा जा रहा है।
This ceremony is evidence of how a community norm is being changed with the approval and participation of the community. The introduction of semi-solid food at the completion of 6 months has been turned into an occasion for celebration. An important milestone has been created. Hands have been washed, the babies and the mothers. Khichdi with green leafy vegetables and with extra oil added has been prepared by the Anganwadi Sevika, and the mothers have bought shiny new bowls and spoons. to mark the moment when their babies will have their first complimentary food.
कुपोषण की स्थिति कहीं से भी शुरू हो सकती है, जैसे कि बच्चे जन्म से, कुंवारी अवस्था में, गर्भावस्था में और पैदा से ही शुरू हो जाती है। लेकिन हम इस बैठक में सीखे हैं कि कुपोषण की स्थिति को तोड़ा जा सकता है।
This doll named Janki is Kamzor. A chain of causes related to nutrition, illness and caring practices has made Janki severely undernourished. The women have identified the causes and now the facilitator asks, can the chain be broken? Is change, Sudhar, possible? She will not take her sick child to the Ojha. She will go to a proper doctor. When she was born, Janki was given goat's milk. We have to give the mother's first milk to the baby. It's good for the baby. The responses are tentative, the women shy and hesitant. But with each meeting they learn more about what they themselves can do and what they can demand from the system. It is this confidence in their agency, awareness of their rights and entitlements that empowers the women to fight malnutrition.
अब अपने बच्चे को कितना बार खिलाते हैं? 2 बार खिलाते हैं। आपका बच्चा 1.5 साल हो गया है, तो 2 बार में उसका पेट भरता है? कमजोर भी है, इसलिए बच्चे को 5-6 बार खिलाना है। तो बच्चे को खिलाने से पहले हाथ साफ सब करते हैं कि नहीं? सब करते हैं, बिना पानी से। बिना पानी से साफ करने से गंदा नहीं जाता है, इसलिए साबुन से हाथ धोना है बच्चे का भी, और खाना बनाने से पहले भी अपना हाथ साफ करना है, बर्तन को भी साफ करना है, उसके बाद खाना बनाना है।
During home visits, the focus is on the individual mother and child. This single-pointed beam of attention on the mother, coming to her home, listening, talking, and supporting her. This is a form of counseling that encourages the mother to be proactive and result-oriented.
मैं अभी इनके घर आई थी। इनके बच्चे का नाम पासी मुंडरी है और इनके बच्चे का वजन बहुत कम है, 6 किलो 700 ग्राम है। बच्चे का वजन बढ़ रहा है, लेकिन थोड़ा अभी बहुत और बाकी है। हाँ, वजन में इसका बच्चा कम है और इसलिए लाल में है। पहले सबसे बहुत कम था, सुबह धीरे धीरे बढ़ रहा है। देखो इसमें दिया हुआ है, धीरे धीरे बढ़ रहा है। उसके बाद बढ़ेगा, फिर पीला में जाएगा, उसके बाद धीरे धीरे फिर हरा में जाएगा। इसलिए हरा में जाने के लिए आपको घर में ही ठीक से बच्चे को देखभाल करना है।
It is said when things get measured, things change. Tracking growth on a regular basis and discussing growth promotion with the mother encourages her to put into practice all that she has picked up in the women's groups meetings and during home visits. The mother knows that every effort that she makes as regards nutrition, hygiene and prevention and treatment of illness will show up on the growth chart and on the MUAC tape. Every step of progress raises her confidence and motivates her to strive for better and better results.
अभी आपका बच्चा पीला से हरा में आ गया है, बहुत अच्छा है। ऐसे ही आप इसका और भी खिलाइएगा तो अच्छा है कि पहले से इसका मांसपेशी बढ़ गया है और बच्चा बैठने भी नहीं सक रहा था, कुछ नहीं, बहुत कमजोर था। तो आंगनबाड़ी दीदी वो बोले कि एमपीसी ले जाएंगे। तो एक बार वो बोल के देखी तो वो सुनी नहीं, फिर हमारा पास आई कि बोले कि चलो हम लोग बोलेंगे घर जाके और वो एमपीसी लेने के लिए। तो हम लोग आए घर पर, तो वो डर से नहीं थी घर में, भाग गई, छुप गई। उसके बाद हम लोग लौट गए। फिर दूसरा दिन हम लोग आए आंगनबाड़ी दीदी के साथ, फिर बोले कि उसको एमटीसी ले जाओ, बच्चा का इलाज होगा, वहाँ दवा मिलेगा। तो ये आयुष्मान में एमटीसी तो ले गए, उसमें क्या फायदा हुआ? अब दवा का सब कुछ मिला ना, खाने के लिए अब दवा सब मिलेगा। तब मैं लोग अच्छा से नहीं चल रहा था, जो हवा गया है ना पूरा गाँव में लेके सकता है बच्चा को। अब तो हवा गया तो पूरा नहीं सकता, और दवा खाने पीने के लिए बहुत अच्छा है हमारा बच्चा, बहुत खुश है बच्चा के लिए।
The creche for children 6 months to 3 years is another way of building trust with the community. The children take time to settle down in the morning, but the 3 meals, the stimulation, the compassionate care, all this shows results in just a few months. The children fall ill less often, gain weight, look more alert, and they simply cannot wait for this daily ritual. The katoris are big, the portions generous. Spoons work as a second line of defense against dirt and illness. Also, holding a spoon, scooping food into it, directing it to the mouth, all these actions promote fine motor skills as essential for physical development, as verbal and visual stimulation is for mental development.
ये जेमा मिल जाएंगे, इनके बच्चे कमजोर बच्चे थे, अभी स्वस्थ हो गए, इनके बारे में हम लोग अभी बताएंगे। मैं ना तो मरी गया थी, तो बनी गई है, कमजोर थे, जल्दी से कम हुई थी हम लोग। दीदी बताई कि जैसे पहले बच्चा कमजोर थी, तो वजन करके ग्रेड दिखाए, तो दिला हमने तो चिंता हो गई, बोल रही कैसे करके इसको खा जाएंगे। बाद में जब मैंने वजन करके समझाई, इसे तरीका से खिलाना, हरा सा सब्जी खिचड़ी बना के, और खिचड़ी में तेल डाल के थोड़ा सा बनाएंगे। फिर चावल का ये शाम को चावल भिजा देती है, सुबह पीस के रोटी बनाती है, उसको खिलाए, और बार बार दूध भी पिलाती रही, और साथ में खाना भी खिलाते हैं। 3-4 बार 5 बार शाम तक में खिलाते हैं, बार बार थोड़ा थोड़ा खिलाई। उसके बाद में फिर आंगनबाड़ी ले गए, जाके देख उसमें वजन भी थोड़ा सा बढ़ गया। और वैसे कोशिश किए सप्ताह के दिन में अंडा मीट मछली जैसे खिलाते हैं, चिकन सब वो भी खिलाई। उसके बाद हरा साग सब्जी हर जगह जो हम लोग बड़े लोग कर रहे हैं वही बच्चे को खिलाने लगी। उसके बाद अभी पूरा स्वस्थ है, और हाथ में थोड़ा सा कांसी हो गई तो कमजोर दिख रही है, बोल रही है गर्मी के चलते, और अच्छा।
बच्चों के वजन जो है वो बढ़ रहे हैं, जो बच्चे लाल में थे वो पीले से अब हरे में जा रहे हैं, बच्चे अच्छे से खाना खा रहे हैं और हाथ धोना सीख रहे हैं, और साफ सफाई पर भी घर वाले ध्यान दे रहे हैं। घर पर भी जाकर बच्चे साबुन मांगकर हाथ धोते हैं, और माँ कोशिश करती है कि शाम बच्चे कम से कम 4 से 5 बार घर पे भी खाना खा सके।
सर, हम सेविका के लिए बोलने से उन महिलाओं या बच्चों में कोई सुधार नहीं होता, लेकिन एक संस्था के साथ काम करके हम महिलाओं को और बच्चों को अच्छी तरह समझा पा रहे हैं। अब मेरे गांव में अभी इस महीना माई में कोई भी कुपोषण बच्चे नहीं हैं।
Not a single malnourished child in any of the villages. The mothers say they can make it happen. Can we respect their agency? Can we walk in solidarity with them as they write another chapter in their story of hope and change? And the child plays on. He is Naman, 2 days shy of his 2nd birthday and 1 point short of the green on the growth chart. But he will get there. His mother will make sure of it. That is in her hands. But she won't take credit for his willfulness. That comes from the father's side. To prove her wrong, the father calls out,
Naman, Naman, haath do.
Naman, wash your hands.
Naman, haath do. Naman, पैर दो.
Naman, wash your feet.
Only 20 seconds. I hope you enjoyed the film. I won't ask you that quiz. Actually, all the elements that are required to combat undernutrition is there, but the additional thing is community empowerment. And so you can have a dumbfoundedly simple intervention, prove it works, and then bundle it with all the other services, etc., that is required, and it can work wonders. And that is what I wanted to show through our work. Thank you.
As often being invited to speak at different conferences, one of the big challenges I have is how to get away overstepping time, not to incur the wrath of the chairperson. Tripathy has given me a new strategy: show a film. So there's nothing the chairperson, as he rightly said, can do about it. But anyway, thank you. That was a very moving film, and especially seeing the willfulness of the child at the end, I think was very nice. But because we're really running short of time, we will just hold the questions, and I'm sure we'll have a chance to move. And if I can just move on to invite Anirudh from CRHP to come and make a presentation on the Napkin project.
First of all, I just want to say that I'm deeply humbled and very privileged to be amongst these eminent people with brilliant minds, and I hope I can do justice and be an adequate stand-in for what the work bureaus have done. I do briefly want to show you 2 minutes of a film about CRHP. It's very similar in the scope and the kind of work that we've seen so far, but I want you to look at some of the differences as well.
काकामुळे आम्हाला मला भीती नाही वाटली. काकाने आमच्या गावात एक काम चालू केलं ना, त्याच्यामुळं कुणीच बाई कोणत्याच बाया डिलिव्हरीला जामखेडला गेल्या नाही दवाखान्यात.
माझं बाळ निरोगी आहे, जन्माला बुद्धिमत्ता देणार आहे. रामबाबांनी सांगितलं लक्ष दिलं आहे म्हणून.
12 दिवस बाळ राहिलं, पण त्याचा आवाज असा आवाज यायचा दूध पिल्यानंतर. आणि मग मला 12 दिवसांनी मग ती बाळ माझं रात्री त्याला गेलं.
80% of problems that cause death in rural areas can be preventable. You have to have the involvement of the community. The Jamkid model is broken down basically into 3 elements. The first is the community element. And in the community element, you have the village health workers, you have the farmers clubs, and you have the self-help groups. Now, the second tier is your mobile health team. The mobile health team acts as a liaison between CHP center and the village itself. And the third component is a primary health center, or in our case, a secondary hospital.
So that makes it easy to adopt.
दवाखान्याचं काम म्हणून आपले वय घेऊन घरोघर जायचे आणि आरोग्य शिक्षण द्यायला लागले की ते काय म्हणायचे, आधी ₹1,00,000 येत नव्हतं आपल्या बरोबर, तर ही डॉक्टर झाले काय छळ करायचे आणि मोर करायचे, ऐकत नसायचे. जाऊन मी हाताने केलं आणि त्याला करून दाखवलं, त्यात अनुभव आला, शेजारचं गावचं एखादं उदाहरण दिलं, तेव्हा या लोकांना विश्वास आला. आता एक साधी दिवस तपासल्याशिवाय आणि मला विचारल्याशिवाय प्रत्येक माणूस मला विचारतो की खरंच हे.
So I also wanted to point out here, and the other panelists are being very humble about this, community-based health is very much a social enterprise, very much a social justice project, and you're seeing this in this video, right? This woman is a Dalit, and she, as far as the other families were concerned, she didn't have a place in their home, but now that she's gained these new skills, there's more respect for her. Her self-worth has grown, and her ability to facilitate healthcare for her community has also grown. And so I just wanted to point out the social aspect of what all these projects are doing. So I'm here representing the Comprehensive Rural Health Project, and I want to discuss the name of our organization very quickly, very briefly. Why are we the Comprehensive Rural Health Project? And I think the other panelists have seen this in their own work. Health is determined by a matrix of different factors, right? We're talking about not only just pills and surgeries, we're talking about agriculture, watershed development, we're talking about how do we build capacity in all these different areas, how do we solve social issues, gender-based violence. I think that's something you have to recognize, and I think we at CRHP do a great job of that. So I'll give you a brief introduction of the organization. So the founders were Dr. Raj and Dr. Mabel O'Reilly. They're pioneers in community-based healthcare in India. And they decided to come to Jamkid in 1970 to see what they could do with healthcare. And they immediately realized that curative services were not enough. As I said before, they realized that healthcare there was going to be accommodating for all the various different factors that go into creating a good health system. Currently, the directors are their children who are carrying on their legacy, Mr. Ravi O'Reilly and Dr. Shobha O'Reilly. So what's the mandate? What did the O'Reillys come here to do? And the idea was to provide a holistic, comprehensive sense of healthcare, especially to the marginalized and the poorest of the poor. Again, I want to emphasize the fact that this is an all-inclusive kind of project. This is a project in social justice. This is about how can we move the whole community forward and not just select groups. After 44 years now of success, very early on, we were seeing great results with the health indicators, and the UN and the WHO have recognized the Jamkid model. And currently the scope is to provide training to international and domestic groups to scale up in various different contexts, and then we also provide direct services to about 500,000 people in Maharashtra. So what are the guiding sort of principles? What's the philosophy here that's made this model work for the last 44 years? First of all, equity, right? It doesn't matter whether you're HIV positive or not, or what caste you are, or whether you have leprosy or not. The idea is we need to provide care to everyone, and there's this radical egalitarianism that sort of guides the Jamkid model. Everyone is entitled to a certain standard of healthcare. Health is a human right as far as we at Jamkid are concerned. Integration, again, as I said before, health is a matrix of different factors, and we ought to accommodate for that. And this model does that very well. And finally, empowerment. Why can't we put health in the hands of the people itself? I think Mukti was pointing this out before. Health is not about hospitals, right? Health is about taking what we see at hospitals and putting it into everyone's hands. This knowledge should be accessible to everyone. So I want to give you a brief overview of our system. And before I get into sort of this graphic here, I want to do a little bit of public health here, right? So in public health, we have these terms proximal and distal. So proximal causes for morbidity and mortality are, there's something dirty in your water, or the reason you're wounded is because you fell, you got punched, or you were a victim of violence. Those are proximal causes. But what the job kit model tries to do is it tries to look at the distal causes, right? So those are the root causes. So take, for example, gender-based violence or women's health. How do we make progress in that field? Why don't we look at our boys? Why don't we start talking about adolescent programs and how we can change the mindset of boys before they become men that end up being abusers in their households? What about malnutrition? Why don't we look at watershed development and enhancing agricultural capacity so we can provide more food on the table? What about communicable disease? Xavier is doing a great job with sanitation. That's a distal cause for issues of communicable disease. And finally, non-communicable disease. It's easy to give someone a BP tablet or give them diabetes medications, but what about changing lifestyle? What about changing diets? This is sort of the work, this is the philosophy that guides what we do. And if you look at this model here, the first thing I want to point out is that the community is on top, right? The community is the one that guides the priorities. And then we respond to those priorities in ways that we see fit, or in ways that supplement their capacity. And so you have the 3 community groups, as Ravi was saying in the video, and then you have our link to the community, which is the mobile health team, and then finally the secondary center for any other pathologies that we can't deal with out in the field itself. And then of course we have a battery of other programs that respond to the concerns of the villagers and the community members themselves. So what are some fundamentals? We want to talk strategy here, right? We want to talk about what kind of things what are the lessons we take away from all of these brilliant panelists and the example that their role is have set. I think the 2 most important things that have guided the job kit model over these years are trust building and community ownership. You have to spend time in these communities, right? You can't just port this model from place to place and expect it to work. There are different cultural nuances in every place. Local, right? Think globally, act locally, as Dr. Bang said. And then community ownership, of course. If there's no input on the side of the community, if people from the community aren't given that role in deciding what their own care is like, then there's no fruit to be had. So I wanted to get into more depth into the 3 parts of the community that we have. Village health workers, again, they're vehicles for social change. Of course, it's great that they take care of 80% of the health problems in the field itself. They're being taught allopathic methods so they can do what doctors do 80% of the time in terms of, say, delivering children or prescribing medication for the most basic things. But at the end of the day, they're also a vehicle for social change. So the example of Nirmala, right? As I said before, a Dalit who all of a sudden has gained this new information and is now uplifting herself socially. That's one of the most key takeaways of this model. Farmers clubs. It's important to have buy-in from all parts of the community. So you need to involve men in this process too. This can't be bore on the backs of only the women in the village. And so I think what farmers clubs do for us is that some of the more socially minded and progressive farmers will come together in each of our project villages and say, look, we were ready to take this risk and support the training of these Dalit low-caste women who have studied the standard 405. We're ready to take this risk and say, look, yeah, you can enter our homes, you can come here, and you can help us with our health care. And finally, women at large in the village need to have access to this information. We're trying to shift the locus of power in medicine away from the hospital, away from the professionals, and towards everyone. This is a power relationship, and we're trying to change that. And I think women's group are a testament to that. Demystification of health. This is pretty much the same thing I was saying. I've provided 2 examples here on PowerPoint, but essentially, local methods, if we're achieving the same kinds of outcomes, there should be no reason why local methods should be looked upon as different or lowly, So if you can achieve the same things with, say, puppet shows or dramas that you're achieving with textbooks and lectures in the professional world, then there's no problem. Use local resources. So I've provided a few examples, but the idea is, if cash on hand is low, if the roads are bad, if you have no transportation, and you're not empowered in that situation. Why go out and try to buy an ORS packet when you can synthesize the same ORS in your house itself, right? So we need to empower these communities and make sure that the people themselves are within, everything they need is within their own reach. And so these are just some examples. Another thing that we really emphasize in our health system in Jamkhed is appropriate technology. So it doesn't make sense to have someone come in and build an expensive sanitation system that needs to be maintained down the line when there's no funding for that kind of initiative. Why not build a soap pit? A soap pit uses local resources. It's within the expertise of the local community, and it has the same outcomes as, say, that sanitation system I was talking about. Same thing with permaculture, right? We can synthesize organic fertilizers instead of importing very expensive, costly things that need a long-term financial investment. Whereas permaculture produces fertilizer that's eco-friendly and is right there, it's available. This is another example of appropriate technology that we utilize here in Jamkhed. I mean, obviously our communities can't afford prosthetics that cost lakhs of rupees. But instead we offer these artificial limbs instead, which cost around 5,000 rupees. So I think a lot of the panelists yesterday were making this point. There is no timeline. There's no set amount of time development can happen, right? This is at the core of development is a change in attitudes and practices. It's a mindset change. And so we haven't labeled our stages as, say, year 1, year 2, it's a continuum. And this happens over a long period of time. But I think what I want to emphasize is that CRHP needs to step back at some point. We as development professionals, if you will, we need to step back. There needs to be a self-reliance at the end of the road. And I think that's what we strive for at CRHP, is that while there are stages, there also is an end. And we try to step back and provide services as needed, but really it should be in the hands of the community at the end of the day. We had a debate earlier today about whether numbers, whether they're important, what role numbers play in development, and whether that's a good indicator of the changes we're making. I mean, I for one definitely believe that change lies within the people themselves, and that it boils down to what's inside here. But of course, in the world we live in today, numbers matter. So I want to give you a few from our project. So if you look at the last 40 years, there's been dramatic gains in the catchment area of CRHP in terms of the most basic indicators. So infant mortality, crude birth rate, antenatal care. And so this gives you a picture of what it was like when the Auroras came, what happened over the last 4 years, and how we compare to the rest of the country. How are we doing? I think this is a good graphic in that sense. Over the years, I just wanted to give you some aggregate numbers. Over the years, you can see all the different activities that we've been engaged in. And again, I think this emphasizes the comprehensive aspect of what we're doing here. It's about taking a multi-sectoral approach, looking at all the different things that health is predicated upon. Scaling up. So currently, we do trainings for people abroad and in India itself to impart the lessons that we've learned in these last 44 years. And this is sort of gives you an idea of where we are and the groups that we've interacted with and where they are in the world. And we hope that they take the fundamental philosophical commitments we've made and the thinking that we have at Jamkhed, and they apply it in their own local context as they see fit. I think it's important. This is a very important point. There's no such thing as replication. Okay, you can't just port the same exact thing and expect it to work somewhere else. You have to take into account every individual community that you're working with. Just to close, I wanted to go over some key insights that we've come away with in the last 44 years. The core of community managed health systems is change in knowledge, attitudes, and practices. And I think all these people here will tell you the same thing. It's about what you do in terms of mindset. Have people really internalize that change? Do they see the benefits of what new knowledge is coming their way, and have they internalized it, or are they going to send it down to the next generation? Second, I think in development these days, especially with a lot of the big funders like Bill Gates, Global Fund, we are becoming very obsessed with glamorousness and how good does our intervention look. But end of the day, it's really, we want the outcomes, right? So we want sustainability. We want it to be something that goes on. We want the intervention to have an impact down the line. And I think that should be prioritized over sophistication or repute or how big it looks. It's about the quality of what happened. And I think the panelists that presented Proto Village made this great point about scaling in. What's the quality of that intervention? And finally, I think the key lesson at JobKit and all the panelists we've seen is that interventions and management strategies need to confer a level of dignity and respect to the people that are taking part in these interventions, right? Like the village health workers, that's such a successful program. Like the government of India has taken the VHW and replicated this as the ASHA, right? The reason it's so successful is because it is a social vehicle. It's because it confers upon these people who previously had nothing. They're either widows or Dalits or what have you. In our project areas, now their lives have been renewed. Their self-worth and self-esteem has gone up. They become actors in their community. They become people that have an impact in their societies. And I think that's the most important thing we can walk away with, is that dignity and respect need to be at the core of any intervention or any project that you have. Thank you. I really appreciate your time.
Now I have the very difficult task that we are 45 minutes, almost 40 minutes behind schedule. So there's one trick we can employ. In the West, I find it every time I go there, I find it very interesting. They have this daylight saving time. So one thing is we can all move our watches back by 45 minutes and we'll be on time and we can finish the next session. But of course, that's not likely to work. So we have to move into the next session. We have a tea break before that. So I'm just holding questions. So all those who desperately want to ask questions, can you raise your hands? All those who have questions? Okay. All those who have questions, please follow the speakers to tea and get them around tea and ask them your questions. Because we really don't have the time for the questions now. I just want to, as a takeaway before we break up for tea, I just want to ask any one of you all, is there one single message that you got from all the three presentations? One single thing that you got from all three of them? In a word or
something very small, sound at a local level could give you a solution which can be applied all over.
Okay, you can say even small things.
Community involvement is the utmost important.
Yes, that is the answer I was looking for. 100 marks to you. That nothing works without community involvement. And starting from the first session, which I was a part of building self-reliant communities, it's in every sector, whether it's health, education, community is at the heart of it. And when we're talking about rethinking development, actually it's going back to many of the things that many of the earlier projects started with. We started with communities. Let's go back to communities and let's realize that they are the focus. And the final thing is a health exercise for everybody before we put tea. So can all of you stand up? Raise your left hand up. Now raise your right hand up. And let's give the three speakers a big hand. And thank you for a wonderful presentation. Thank you very much. And let's go to tea. Oh, sorry, there's one more formality. We just need to present these things. Just hold on for a minute. I forgot about this. So, I already got one. Okay, so now let's all go for tea. Thank you. And come back in 15 minutes.
The tea starts. We'll start the tea session at 4:30. The tea is on that side.